I have the honor to introduce Dr. Sharl Azar. He is the medical director of the Comprehensive Sickle Cell Disease Treatment Center and the Robert K. Kraft Chair of Diversity, Equity, and Inclusion at Massachusetts General Hospital and Harvard Medical School. He received his medical degree from Oregon Health and Science University, where he also completed his residency in internal medicine and his fellowship in hematology and medical oncology, while also serving as chief fellow. He went on to complete an advanced fellowship in hemostasis and thrombosis at University of California, San Diego. Dr. Azar is passionate about the care of patients with sickle cell, thalassemia, and other hemoglobin disorders, and his work really focuses on improving systems of care and political advocacy for patients living with sickle cell to build a true medical home while combating inequities in healthcare. He's at the Sickle Doc on Twitter, Bluesky, and Instagram. And without further ado, I will hand over the presentation on the history of sickle cell.
Well, thank you so much for that introduction, Maya. Thank you both for thank you all for having me. It's a real pleasure to be with you guys today. So let me share my screen and hopefully get this up and running here. Okay. Can you guys give me a thumbs up that you guys can see my screen? Amazing. So it is really a true pleasure to be with you guys. And we were talking before we got started today. I'm going to say a lot of words in today's talk that the federal government may be less than thrilled that I'm using, but I think it is very important for us to be able to rip the Band-Aid off and call a spade as we talk about these very important issues. So, when I was in college, I was actually an art history minor. And I will still say to this day that I've used my art history minor far more than I've ever used my biochemistry major in college. And whenever I give a talk, I really love to include art. And so that's going to play a prominent role in the conversation that we're going to have today. But I start with this piece of art because it's really one of my favorite paintings. It's long been one of my favorite paintings. This is a painting by Jean-Francois Millet, painted in 1857, called The Gleaners. And this painting depicts these three anonymous women who are really at the front and center of the image out in the French countryside. And the gleaners were the people who were allowed to go into the field for the harvest last. So the lord of the manor, the owner of the land, would get to go through first with his servants, obviously, and pick the first crop. And then the servants themselves would be allowed to go through and pick what was left over. The gleaners were the people that were then allowed to go into the field and pick up the scraps that had not been picked up by other members of the household. And I think this is a very apt metaphor for what it is like to take care of patients living with sickle cell disease. And we're going to come back to this image of the gleaners again later on in my discussion. But over the course of the next few minutes, my hope is to be able to demonstrate for you how the history of sickle cell disease in this country really echoes the lived experience of the Black and brown people that suffer with this disease in the United States. So all of you are amazing providers in the sickle cell space already. And so, nothing that I'm going to present to you all today is not anything that you haven't heard 1,000 times before. In fact, if we lay out the agenda for the next 20, 30 minutes or so, I'm going to lay out for you things that you all already know. But first, let me give an example of a patient who I think really summarizes what we're going to be talking about very well together. And this is probably a story that all of you are all too familiar with in your own practices as well. This is the story of a young man named Jeff. And Jeff is 30. He has SS disease. Jeff has suffered multiple complications from his disease. He had his first stroke when he was 3. He had bilateral osteonecrosis of his hips. He's gotten one of them replaced. He's had multiple blood clots, both in his lower extremities and his lungs. He's on chronic anticoagulation, and he suffered hyperhemolysis syndrome, which makes it very difficult for us to be able to transfuse him. But this is really just one thread in Jeffrey's story. Because of the fact that he suffered with these complications of his disease his entire life, he has significant depression. His multiple hospitalizations over multiple years across multiple institutions have given rise to post-traumatic stress disorder, and he has suffered significant anxiety related to his disease as well. But even this is just one thread in his ultimate story. Because he's had to seek care across multiple institutions, across 3 different states, he has really struggled with trust. The barriers were way, way up when we first met him. And he was accused of drug seeking. He's been taken off all of his opiates and put on Suboxone without anyone really telling him what that meant. All of these things have sort of fed forward into the anxiety and PTSD that he's suffered. And this is really just another thread in his story because as a result of all of these things together, Jeff has had challenges holding down a relationship. He's been unable to keep a job and he's been unable to finish school. And these things together form this big, fat, tangled knot that we call sickle cell pain, what I prefer to call sickle cell suffering. And we try to treat this entire thing with IV Dilaudid and then marvel at how it doesn't work. We're going to come back to Jeff's story at the end. But as I was mentioning to you guys, nothing I'm going to tell you over the next half hour is anything y'all don't already know. The agenda today is literally this: what you already know, what you really already know, and lastly, what we can do about it. So let's start with what you already know. Everybody on this call already knows that sickle cell disease is the most common inherited life-threatening blood disorder in the world. And in this country, we estimate that it impacts about 100,000 people alone. But as everybody here already also knows, that number hasn't changed in 30 years because it's mostly made up. Because this is a disease that predominantly impacts Black and brown people, we are so far behind in our understanding that we don't even know how many people are actually impacted by the disease in this country. And when you look at the statistics, that 1 in every 14 Black babies is born with trait, 1 in every 365 Black Americans is born with the disease, and 1 in every 15,000 Latinx Americans is born with the disease, and you extrapolate that over the Black and brown population in this country, you'll see very quickly how that 100,000 number doesn't make any sense. But I think we all also know that sickle cell disease is really a global illness and that the minority of people suffering with the illness are living here in the United States. The vast majority of people are living outside the United States. And the reason why this disease has continued to be a part of the human genome, to be preserved over many, many centuries, is because it confers some protective effect against malaria. So the disease is endemic in areas where malaria is equally endemic. That accounts for sub-Saharan Africa, the Middle East, the Indian subcontinent, going into parts of Latin America and the Caribbean. We all also recognize that sickle cell disease, the reason why most of our patients will seek their care with us is because of pain. It is the #1 reason that brings them to medical attention, and it peaks right around the time that I, as an adult hematologist, get to inherit these patients, right around the ages of 19 to 39. And while we know very little about what the end of life in sickle cell disease looks like, thanks to an abstract at ASH that was published by our colleagues at UAB a couple of years ago, we do know that as the episodes of pain crises become more frequent, the mortality also increases with that as well. And we know that while anything under the sun really can trigger a crisis, most of the time our patients really can't point to one particular thing that actually brought them into the hospital in the first place. What's very important and what is so clear that I emphasize repeatedly to our trainees here at Mass General is that there is no lab or imaging study that can accurately identify an uncomplicated pain crisis. And this is as much of a burden to us as evidence-driven providers as it is to patients who have to validate to their providers that they're actually in pain. And when you talk to our patients and you ask them what this feels like, I think all of you have heard descriptors like this before. They'll say things like, this is the sensation of hot pokers running through my body, or this is the feeling of all of my bones breaking from the inside, or it feels like broken glass is being poured through my veins. It is was called by the former director of the NIH, one of the worst pains known to humanity. But something that I think a lot of our colleagues who don't practice in the sickle cell space fail to understand is that this is really an internal medicine disease. This is a disease that touches every single organ in the body. We all know about painful osteonecrosis. I'm actually in clinic right now, and I just saw a patient who had brand new osteonecrosis of her joints. This can lead to our patients getting their first joint replacement before they're even 30 years old. We also know our patients have early onset osteoporosis and vitamin D deficiency, yet insurance companies refuse to pay for screening tests for these conditions. We know that if we don't screen our patients for chronic kidney disease, they can develop progressive renal failure and become dialysis dependent. A quarter of our patients get their first stroke before they're 40. You recall Jeffrey, the story I was telling you guys at the beginning, had his first stroke before he was even 5. Now, as our patients are finally living into adulthood, we're seeing increasing rates of heart failure and heart attack. Many of our patients will suffer their first type 2 MI before they're even 25 or 30 years old. They will go on to develop pulmonary hypertension that can give rise to heart failure. We have our patients see our ophthalmologists yearly to prevent them from going blind. They develop painful skin ulcers, which frankly are one of my least favorite complications of this disease, given how little we have to be able to manage them. And our patients can then go on to develop infertility and develop painful priapism, for which we also have very limited treatment options. So really and truly, from head to toe, this is a disease that really does not spare a single organ. And I think all of you are very well aware of the painful landscape of limited treatment options that we have, of which hydroxyurea has been the cornerstone for the last 3 decades, and that hydroxyurea got approved out of the MESH study back in 1998 because it remains to date the only therapy that has actually been shown to improve mortality in this disease and meaningfully reduce the rate of pain crises. Many of our colleagues will often think about they'll say things to me like, well, sickle cell disease, isn't that cured now? Isn't that fixed? Isn't that something that we've got great treatment options for? I thought all these new drugs were coming out over the course of the last 5 years. And in fact, that the coming out of these new drugs was why my, to be blunt, racist institution finally became interested in having a sickle cell program, and recruited me here to build this program 6 years ago. But the reality is, as all of you know, the landscape is not nearly as optimistic as our colleagues may have heard in the popular press. L-glutamine was shown to decrease hospitalizations by a very modest amount. You all know it's a powder that patients have to mix into a glop, that insurance weirdly still struggles to pay for this powder, that you can get it from a nutrition store, and that it's weirdly still very expensive. We all know about voxelotor and that it was approved out of the phase 3 HOPE trial, which ultimately showed that it did nothing to improve pain, but only raised the total hemoglobin by 1 point. And crizanlizumab, which was super exciting when it first came out and got all of us really optimistic that we would finally have something to compete with hydroxyurea, ultimately was shown through the phase 3 STAND trial to be no better than placebo. And in the last year and a half, we've seen this so-called revolution in sickle cell therapies really fall apart. Crizanlizumab got pulled in Europe. Voxelotor, as you all know, got pulled globally in September. And L-glutamine sucks. So we're left with hydroxyurea, the same drug that we've had for the last 3 decades. What about stem cell transplant? Stem cell transplant's great if you can get it. There's, as you all know, many limitations built into our system that prevent our patients from being able to have access to this. First, you have to be able to get access to a center that has experience in transplanting sickle cell patients, which is a limited thing across the country in the first place. But also, when the ASH guidelines finally were released around transplant and sickle cell disease 4 years ago, they really recommended that the optimal time to do this is as young as possible, because the mortality raises quite substantially after the age of 12. And as we all know, what you walk into the transplant with, you walk out of the transplant with. So the optimal time to do this is before patients have accumulated the multiple complications of their disease. But try having a conversation with an 11 or 12-year-old about doing an intervention that could potentially cause them more harm down the road and might potentially rob them of their ability to have children when they haven't even begun to think about starting a family at that point. We also know, for reasons we don't fully have an explanation for, that patients with sickle cell disease have higher rates of graft failure and graft versus host disease, that conditioning chemotherapy causes multiple side effects, and the prolonged hospitalization in our patients is very challenging for them to be able to tolerate. And then comes the challenge of being able to find them a match in the first place. A matched sibling donor is hard to come by in a disease that can affect multiple members of the family. And when you don't have a matched sibling donor and you have to go into the National Bone Marrow Registry, 80% of white Americans can find a match, whereas only 17% of Black Americans can successfully find a match, which makes it all that much more difficult for our patients to consider this treatment option. We all know about gene therapy. Everyone's talked about gene therapy for the last year since it's become commercially available. And interestingly, gene therapy got approved by the FDA on what was the first day of ASH a year ago. And I think the scientific community was really excited and doing backflips. But I think all of us who work with our patients recognize that in the sickle cell community, there were some anxiety around this. And that's because this treatment came with a whole host of unanswered questions, many of which we still don't have a good answer for now. The treatment is super expensive. Casgevy's $2.1 million. Lyfgenia is $3.2 million. That doesn't count the additional $1 million that you need for the transplant itself. Ultimately, the decisions that we make and how we roll out gene therapy here in the United States, where we have resources, is going to directly impact how we get access to this treatment where the vast majority of people with this disease live, not the United States. We're talking about countries that barely have access to hydroxyurea. So are we going to be creating a global setting where you've got the United States and Western Europe, these countries that have access to this resource, and then the rest of the world, where the vast majority of these patients are living, who don't have access to this resource? Is that going to divide out the population in a very scary way? So the decisions that we make today and how we scale this are going to directly impact that. We also don't know who the ideal candidate is for gene therapy. At the National Alliance of Sickle Cell Centers meeting that Maya and I were just at a couple of weeks ago in Vermont, maybe some of the rest of you were there with us at that meeting. If you happen to be in the room where we were talking about the consensus guidelines for gene therapy, you recognized how frustrating it is because there is so little consensus about who is the right person to be able to go through this. At the same time, who covers the costs that are associated with this beyond the treatment itself? For example, who covers the cost of fertility preservation? Here in Massachusetts, where I practice, our Medicaid will cover fertility preservation for patients who are undergoing gene therapy for myeloma, leukemia, lymphoma, but it will not cover it for my sickle cell patients who are undergoing a bone marrow transplant. And because this is such a resource-intensive intervention, how do we ultimately cull together the resources to help our patients overcome the social determinants of health that are already barriers to them just seeking routine care in our clinics, let alone the care that's going to be required when they have to come in and out over and over and over again? So we've talked about the disease. These are all things that you guys already know. Now let's talk about what you really know, which is why we know so little and why we are so behind in our understanding and our management of this disease. So to give you a quick sense of the landscape in chronic congenital disease, and again, this may be something many of you are familiar with working in hematology on the whole, hemophilia is federally funded. 1974, Congress passed a law that allowed the CDC and HRSA to be able to provide funding and establish a standard of care in hemophilia. As a result of this, hemophilia treatment centers were established that must meet this very lofty federal standard. And in order to be able to maintain the resources to meet that standard, they are provided millions of dollars by the federal government. Many of those millions of dollars end up being returned to the federal government at the end of every year unused. If we could have those leftover dollars, if we could be the gleaners, then we could change the landscape for the management of sickle cell disease. But it is explicitly written into the letter of the law that these resources cannot go to the use of sickle cell disease or other hematologic illnesses. To date, there's about 140 federally recognized, federally funded comprehensive hemophilia treatment centers around the country. Cystic fibrosis has done this beautifully. Cystic fibrosis is not federally funded, but the CF community came together in a very robust way and formed this extraordinary national organization that has centralized their standards of care, that accredits and recognizes their multidisciplinary CF centers around the country, and very importantly, brings together funding resources so that that funding is equally distributed across these centers so that no one has to compete for or fight for philanthropic dollars or national resources. There are over 130 CF centers around the country today. This is probably a graphic that you all have seen 1,000 times. This compares sickle cell disease to CF. And this is by no means intended to demean or diminish CF. CF is an absolutely horrible disease. And in fact, it was in working with CF patients that I first became interested in working with patients living with chronic congenital illness. But the incidence of CF in this country is lower than the incidence of sickle cell disease. And sickle cell affects primarily Black and brown people, while CF primarily affects white people. And we are, despite those things, we are outspent at the NIH 3-1. We are outspent by industry funding 2-1. We are outspent by philanthropic funding 80-1 compared to cystic fibrosis. Ultimately, the reason for this is simple. Our American healthcare system is intrinsically racist. So let me walk you back through some history to help you understand why the lived experience of our patients living with sickle cell disease really echoes the history of the Black and brown lived experience in this country on the whole. And I can take you all the way back to American chattel slavery, where Dr. Samuel Cartwright described this illness called dysesthesia ethiopis, completely made up. Totally made up disease that basically amounted to the idea that Black people experience pain differently than white people. In other words, you as a white slave owner could turn the whip onto yourself and it would feel more painful than if you turned it onto your Black slave. So you should not feel ashamed that you are hurting them in any way by beating them into submission. And while many of my colleagues today probably have never heard of Dr. Cartwright, and I've probably never heard of dysesthesia ethiopis, I would contend that this was such a cornerstone, such a foundational component of the American healthcare system at its nascence, that it is still the reason why my patients who are in a stretcher in the emergency room get their pain treated differently than the white patient on the stretcher 2 beds over from them. I told you guys at the beginning that I really like art. This is a painting of Dr. J. Marion Sims. Dr. Sims is considered in medical history to be the father of modern OBGYN. And it was largely because he developed many of the procedures and tools that are used by modern obstetrics and gynecology experts today. This painting depicts Dr. Sims there at the end with his 2 white residents. And the 3 women in the room are 3 Black slaves. Anarcha, the woman on the table, had tens of medical experiments conducted on her against her will that ultimately led to many of the procedures that are still used in OBGYN today. And all of these procedures were done without anesthesia because Dr. Sims believed in dysesthesia ethiopis, that he was not affecting these people by treating them without anesthesia. But as soon as he had confirmed that the procedures were effective, he then went on to perform them on white women with anesthesia. We're going to come back to Dr. Sims's story at the end of my talk. Those of you who remember your high school social studies will remember the paradigm of Jim Crow, the idea of separate but equal. And supposedly the era of Jim Crow is over, but I would contend that it is very much alive and well, as any of us who have had to go to our C-suites to get resources for our sickle cell centers have experienced directly. I have been frequently told by hospital leadership, well, Sharl, you have the same amount of MAs and nursing staff and hospital rooms and front desk staff as the clinic down the hallway. But the reality is we are so behind in our understanding and our ability to manage this disease that giving me what is equal is insufficient. And equality is not equity. I need to have more resources to be able to even catch up to the starting line of the marathon that all of us in healthcare are running against each other in the care of our patients. Why are we so far behind in our research understandings? Well, because of this, because our patients are very familiar with the legacies of Tuskegee and Henrietta Lacks, along with countless other examples where our research complex in this country has gone forward with medical research on Black and brown people without disclosure, without consent, further building the mistrust within our healthcare system and leading many of our patients to be afraid of participating in clinical trials. And if we fast forward even a little bit further forward in history, we get to the era of redlining. On the screen, you see a map of Redline Boston, where I live, where I practice. Redlining was the idea that city planners sat down amongst each other and took a marker and literally drew lines on the map where they would determine where some of the most valuable land was and where certain members of the community could live. This is today the reason why my patients have to drive many, many miles to be able to see me in clinic, why they don't have access to primary care anywhere close to them, why they don't even have access to grocery stores with healthy food or clean water or clean air in their own backyards. Our attitude as providers, as we take care of our patients, matters. Even though our center's now been here for the last 6, going on 7 years now, we walk around the hospital and we hear stuff like this all the time. The patient can't be in pain because they're asleep or they're on their phone. The patient has to be a drug seeker because they're coming into the hospital and they're asking for a very specific pain regimen. As you all know, our patients have been exposed to opiates since they were infants. Of course, they know what regimen of pain works best for them. Their parents have trained them in coping mechanisms that helps them to be able to turn to their phone or to try to fall asleep or to distract themselves on their tablet or to put the blanket over their head in an effort to try to shield out the world that has been hurting them for so long. Our patients are told if you act too much, the doctors won't believe you. If you act too little, the doctors won't believe you. The fact that they have to act at all when they are in their worst is absolutely disgusting. And we all know that the rates of opiate misuse in our population is lower than in other chronic pain conditions and in the general population overall. This study at the bottom of this slide is really one of my favorites. This study took 413 med students, internal medicine residents, and ED residents, and they exposed them to one of two medical records. The only difference between them, they were both in a sickle cell patient, and the only difference between them was the language that was used to describe the patient. And the trainees who read the notes that used the more biased language were far more likely to select a less aggressive pain regimen and have a more negative attitude about the patient. And the further along they were in their training, the worse their attitude was. So this tells us that this is a learned behavior and that we are passing it on to the next generation of doctors and nurses and APPs. So what can we do to try to change this depressing landscape that we're in, that we find ourselves in? This is one of my favorite quotes. If you follow me on social media, this is at the top of all my social media pages. This is written by Nat Turner, who led a famous slave rebellion in the 19th century. The time was fast approaching when the first should be last and the last should be first. 200 years after he wrote this statement, I think we are actually entering the era that Nat Turner was predicting was going to come about. This is my amazing team here at Mass General. This is how we combat this boots on the ground here at Massachusetts General Hospital. I am the least important person on this screen by far and away. I have two extraordinary nurse navigators who are truly the ones who run this show. An amazing social worker who I pay way too little to do the extraordinary work that she does. We have 7 primary care doctors who are embedded with us in clinic so we can create one-stop shopping for our patients. We have dedicated optho, renal, transfusion medicine, pulm, and orthopedics, as well as OBGYN. And we have a pain and suffering management team that brings together our palliative care doctors, our integrative therapists with acupuncture and massage expertise, and our dedicated spiritual care provider to be able to help manage our patients' pain through a multimodality approach. We're also really lucky to be able to have a medical exercise specialist that I'm going to tell you guys about here in a couple of slides, who helps to build athletic training programs for our patients as well. It really takes this entire group of people together to be able to take care of our patients. And this multidisciplinary approach is really the primary way by which we can combat many of the injustices that I was talking to you about before. But let's go beyond this. So what are we doing on a systems-wide level? Well, to date, there have only been 2 major pieces of legislation that have been passed on the federal level to be able to help us change the landscape in sickle cell disease. The first of these was the National Sickle Cell Anemia Control Act, all the way back in 1972. It was the first, and up until very recently, the only major piece of legislation passed in sickle cell, and it helped to create some educational guidance and some screening and genetic counseling tools that are still very much embedded in the way that we do things today. It created the very first, although very minimal, federal funding programs for sickle cell disease, and ultimately it got signed into law in May of 1972. And it remained the only law on the books federally for sickle cell disease until 2018, when this big mouthful of a named bill came out that basically just reauthorized a lot of the things that had been put in place in 1972, but then helped to establish potentially some resources for the CDC to be able to push forward with other grants that might be able to help change the landscape slightly. Both of these are relatively anemic bills, but they are the only pieces of legislation that we had and that we still have to date federally. What's what are we trying to accomplish right now? Well, HR 6216, the Sickle Cell Disease Comprehensive Sickle Care Act, was put in place by two representatives, and it was introduced initially to the 117th Congress. It's been reintroduced every year subsequent to that. This bill has provided, would aim to try to provide funds through Medicaid to be able to take care of our patients with a special focus on our adolescent young adult patients and pregnant women. It would empower the Centers for Medicare and Medicaid to create these grants that would then be able to fund initially a cohort of about 5 to 10 states, and hopefully then create a model by which we could build out multidisciplinary care, much akin to what we provide to hemophilia. It was first introduced to Congress in December of 2021. It passed through the committees fairly quickly. It picked up several co-sponsors on both sides of the aisle. It ultimately ended up passing the House, moved to the Senate, where it has languished and essentially died ever since then. So, with very little happening on a federal level, we really turn our attention to what we can do on a state-by-state level. And on the screen, I've put a listing of just some examples of what many of our colleagues around the country, what many of you perhaps around the country are doing in your states. And you can see that there's a wide variety of states here, both red states and blue states alike, that have done some really great things to be able to move the needle. And this, I think, emphasizes why real change is going to happen on a state-by-state basis while we wait endlessly for the federal government to finally do anything. Everywhere from Louisiana to Georgia, North Carolina, New York, Pennsylvania, New Jersey have done things like introducing statewide registries so that we can actually finally understand how many people are living with the disease. California passed an amazing piece of legislation that created a funding source to be able to build out new sickle cell centers in their state and keep them funded. In the state of Florida, in the state of Illinois, additional grant programs have been introduced to the state legislatures. In Kentucky, Medicaid expansion has been changed over to help cover sickle cell disease. Mississippi is extending medical marijuana laws to cover patients with sickle cell disease. And North Carolina is trying to do the same thing. And in my home state of Oregon, where I trained, they are attempting to use state resources to actually build out state supports to be able to pay for resources to help our patients get to clinic or have childcare or food security. Imagine that. Imagine the state being able to help our patients overcome those barriers. So really, across the country, a wealth of things are being introduced to be able to try to change the landscape. This is what we're doing here in Massachusetts. We got very tired of waiting. So 3 years ago, we actually drafted and introduced the first bill with one of our state legislators. And it is now House Bill 1346 and its sister bill, Senate Bill 788, has been reintroduced to our state legislature. It attempts to take what many of our colleagues around the country, what many of you perhaps have done, and expand on it in an omnibus bill. So it creates a statewide registry, like so many other states have created. It creates a commission that brings together patients, their families, politicians, providers, members of industry to be able to create a report for the governor on the state of sickle cell disease every year, to set a standard of care and to lead the state to be able to fund that standard of care so that if my patients are getting their care on the western part of the state or they're getting care on the eastern part of the state where I practice, they can count on getting equal care. It will also pay for fertility preservation for our patients who are exploring gene therapy or bone marrow transplant. And it would provide social support services so that our patients don't have to worry about housing or food or childcare to be able to get their medical care. This bill almost made it across the finish line last year. We came really, really close. And this year, we're very excited. We're very hopeful. It's going to be able to move all the way across the finish line. The Speaker of the House has endorsed it. We just had a huge advocacy day at the State House for this a couple of weeks ago, and we testified before the first committee a couple of weeks before that. So we feel really optimistic we're going to make this a reality this year. Let's talk about what all of us could do to be able to do the same thing in all of the states where you live. I think all of us as medical providers are very reticent to participate in the political system. And I think it's because we say things like we don't have the bandwidth, or we have a very limited understanding of the political process to be able to participate. The reality is, most of our politicians don't have an understanding of the political process. You don't need to have an understanding of the political process to be able to evoke change within our political system. You really only need to understand the plight of our patients and be willing to use your voice where they cannot. Most of our politicians don't understand this disease. They don't understand what the lived experience of our patients. Some of them don't even know that this disease still exists. And while so many other diseases have ample funding, like cancer and CF and diabetes, our legislators need to be educated about this disease. And many powerful lobbying groups are working to raise awareness of these other diseases. We don't have that. So we have to try to be that voice to try to educate our politicians. And I would say that many of our politicians are very interested in working with providers who would lend a sense of credibility to any piece of legislation that they would be trying to move. Our patients ultimately are paying attention to this work. And I think doing this work overcomes the trust barriers and goes beyond the performative box checking that many of our patients unfortunately feel like much of the medical system is providing them. So I've put together this really quick guide for all of you guys to be able to participate in advocacy right where you are, right at your state, right at your institution, wherever you are practicing. It's as simple as being able to find your institution's government relations office. And if you work for a major hospital, your institution has a government relations office. Chances are they're already working on many things that you're not interested in, but you can go and help them to be able to shift their focus on the work that you're doing as well. These organizations can do all the heavy lifting for you. So they can help to draft legislation. They can create petitions to the state government. They can help introduce you to state legislatures. They can help to shape policy that you can just sign your name to if that's all that you want to do. But they can also help you to craft that stuff on your own and help you meet the people who can actually make it happen. It sounds really trite to say that you should write or call your congressperson, but it actually is very effective. Our federal congressperson here at Mass General has been an incredible partner to our center in helping our patients to stave off some of the deportation notices that they're getting from the federal government. He helped us to bring one of our patients who was deported to Rwanda back to the United States so that he could get care. This is what they're there for. This is what they're there to help with. But on the state level, our state legislators, who are oftentimes overlooked, are really anxious to find a partner who can help them to lend credibility to pieces of legislation that they're trying to move to make the plight of our patients better. They want to meet with you. The way I got that bill introduced into our state legislature was by blind emailing my local legislator in the state and saying, hey, are you my local representative? And staff responded to me and they said, we are. And I said, I'd love to meet with you to talk about sickle cell disease. And they met with me. And then very soon after, I met with him. And then he said, let's introduce a bill. And that's how it came about. So it really works. And then lastly, social media is all around us. It is very powerful, and it is a great way to be able to raise our voices. If you don't have your own social media presence, you can join on to the social media presence of your institution, your sickle cell center, or your CBO, who are probably doing a lot of this work already. To make this easier for you, this QR code, if you aim your phone at it, will take you to the resources for advocacy and the legislative process, many of which I've talked about today. It leads you to this incredible website, One SCD Voice. It even includes kid-friendly language so that the kids can actually get involved in sharing their voices to our political representatives. This QR code will help you to find the name and the contact information of your local representative so that you can actually reach out to them directly and contact them just the way that we've done here in Massachusetts. And if you prefer to contact them on social media, this QR code will show you the social media handle of your governor and your state representatives so that you can at them on Instagram or Twitter or Blue Sky or whatever you're on. Here at our center, we really have aimed to try to help serve our patients where they're really hurting the most, which is outside the four walls of our clinic. We, through philanthropic funding, have been able to build vocational training for our patients, help them with housing support. We have money to help them pay the bills when they're hospitalized for a month. We have a partnership with Uber Health that allows us to be able to get our patients to and from our infusion center without them having to drive themselves. And we have a cell phone that we text all of our young patients with. And so if they can't afford a cell phone, we have some philanthropic funds that allow us to be able to provide them with mobile support and pay their phone bill for a year so they can text us. All of this is philanthropic, though. My institution doesn't give me a penny of this. And if the philanthropic interest in this disease dries up, so too do all of these resources with it. This is why a systems-based approach is so critical, because we cannot all exist on this. We need a centralized repository of resources that we can depend on. I told you guys I would tell you a little bit about our medical exercise program because I'm really proud of it. Our medical exercise specialist, Jen Miramontes, creates personalized athletic training programs for our patients. And I share this because I get to show this amazing photo of one of our amazing warriors, Amy, who ran the Boston Half Marathon 2 years ago. She was the very first sickle cell patient to be able to do it. She ran it with Jen, who is the white lady in the white hat who's running it with her in that picture. And Jen and Amy are currently training for the New York Marathon now, hoping to be one of the first sickle cell patients to be able to run that. It's possible. It's doable. We, again, do this with resources that philanthropy, unfortunately, has to pay for. And we try desperately to be able to be as engaged in the community as possible, being out at resource fairs, health fairs, as much as we can, so that we can show our patients that we are right there with them, boots on the ground, as much as we possibly can. So to tie us back, to bring us towards the close, let me go back to the story I told you guys right at the beginning of this young man, Jeff. And you might recall that this was a 30-year-old young man who'd really suffered multiple complications from his disease, with a lot of psychosocial concerns around his illness and well-being as well. When we met Jeff, the walls were way, way, way up, way up. He had come from 3 different institutions across 3 different states, and he had openly told us that we were basically the last hurrah. That's it. If we weren't going to work out for him, he was really just going to give up on continuing to get longitudinal sickle cell care. So we recognized, I think, right from the get, and this is where my nurses are just so amazing, that we needed to try to earn trust, and to do that, we just decided the simple thing we were going to do is just show up. So Jeff was hospitalized frequently. He was in and out of the hospital every 2 weeks. And every single time he'd come to our infusion center or he'd come to the hospital, one of the members of our team, one of the people on that slide I showed you earlier, would just show up and sit at his bedside. And little by little, I think Jeff began to realize that we weren't going to go away. And eventually, he began to open up to us more and more about his life, to the point where about 1.5 years ago or so, Jeff came to us and told us that he really wanted us to help him get on this plane to go to Australia. As you all know, getting our patients to get on an airplane to fly an hour is challenging enough. To get into Australia is a whole other kit caboodle. We literally discharged him from our hospital to Logan Airport so that he could get on that plane, because he told us the reason he wanted to make this trip was so that he could propose to his girlfriend. And remember, this is a young man who couldn't even hold down a relationship. So we knew he had to do this. 2 weeks later, he comes back from Australia and he shows us the video of him getting down on one knee in the restaurant in Sydney and proposing to his girlfriend with the rest of his family around him. About 1.5 months or so ago, we attended Jeff's wedding, where he actually tied the knot with his incredible girlfriend, Larissa. And since that time, Jeff has been admitted to the hospital maybe once every 6 months. What changed? It wasn't because I changed his hydroxyurea dose. I didn't give him gene therapy. I didn't give him a bone marrow transplant. We showed up. That's what it took to change the landscape for Jeff. And untangling that big knot that I showed you guys at the beginning really requires us naming, recognizing, and trying to overcome the racial disparities that are on full display in the management of this disease. Our patients exist at this intersection of the opioid crisis and the national reckoning with race. That is a horrible place for anyone to have to live. But by augmenting their stories, by sharing their stories, by lifting up their voices, we can go beyond the box checking and demonstrate to our patients what real partnership actually means. Because while all of us recognize that sickle cell disease is a cellular disease, it's a genetic disease, it's a molecular disease, it is above all of these things a systems disease. And if we do not change the system, we will never change the way we care for our patients. So I started with a piece of art. I'm going to end with a piece of art. In the middle of my talk, I showed you guys the painting of Dr. J. Marion Sims, who you might recall we regard as the father of modern OBGYN. And in that painting, there were three women. This sculpture, which went up in Birmingham, Alabama, about 4 years ago, I think, 3 years ago, by a contemporary artist, depicts the three women in that painting. The artist calls this the mothers of modern OBGYN. And it's a far cry from the painting I showed you right at the beginning. We started with these three anonymous women, and we've brought ourselves to the point where the three women are the main character of their own story. We've changed the system to be able to afford us that in the course of the last 200 years, but there is a long, long way for us to still go before we can tell this story to its completion. And with that, I will stop, and I will be very happy to take any questions, but I'm so grateful to you guys for your attention, and I'm so sorry to have run over time, Maya.
No, I'm honestly, when we didn't have a case, I was very happy to email you that you do not have to rush, because it's always such a pleasure to hear you speak, and you're amazing in so many different capacities, and just seeing the team that you've built. And I think trying to almost demystify political advocacy, because I think it is intimidating for us as providers, or even not even as a nurse practitioner, as social workers. We have power in numbers, and I think sometimes people might think, oh, somebody else is doing it, I don't have to, when in reality, it's so important for us because we do have power in numbers. So I really appreciated that slide to kind of show how we can start making that impact beyond just our institutional level. Does anybody have any questions or comments for Dr. Azar? I had chills with that, literally head to toe chills when you showed the picture of the marathon runner. And it shows we don't want sickle cell to limit our patients. We want them to live as fulfilling lives as possible. And it shows how having that comprehensive care and a multidisciplinary team to support is so, I mean, it's integral for that. And I'm so intrigued from your pain approach. And I kind of want to connect offline and learn about the spiritual aspect, just my own personal interest from integrative approaches and whatnot from pain management. I think it'd be really interesting to hear from a spiritual standpoint and integrative approach what your patients are receiving.
Yeah, I mean, and thank you for saying that. I think that we all should have access to these kind of resources. And I also should not have to be living in constant fear that if my philanthropic dollars dry up, that all of these resources are going to go away from my patients. So we have to create a systems-wide change to be able to, across the country, whatever state you're in, be able to have equal access to these resources. Hemophilia patients do. CF patients do.
Well, it's like 50-50 between hemophilia and sickle cell. And my first day of the job, literally first week, is what fueled my sickle cell advocacy, because I'm literally in two different diagnoses, and you see the difference with care, attitude, and treatment. And more recently, in the past few years, I actually learned more about the history of cystic fibrosis. And it was really interesting to find out that cystic fibrosis used to be highly stigmatized and misunderstood, similar to sickle cell. And it wasn't until they actually discovered the gene that caused CF, which then led to advocacy and advancement treatment options, et cetera. And I feel like we're very much delayed, but I feel like we're kind of at that tip right now with sickle cell. So I am very hopeful. I think I'm getting the tingles now. So I know my higher ups are confirming this, that we're right in the beginning and the cusp of getting equal access. And I know that in 10 years, 15, 20 years from now, we're going to look back and be like, can you imagine that this is the type of care individuals with sickle cell were receiving? And we'll have a day where this is just all standard of care. It's not anything extra to have an integrative approach, or to have a physical therapist help you run a marathon if that is what you so desire, et cetera. So I think we're in the beginning. It's very exciting. I've been an NP for over a decade, and in the last 5 years, I really have seen and felt a change. So I am very hopeful, and just seeing all of the advocacy you do and just everything that you've listed from across the country, it really is hopeful that amongst all of this political turmoil and negativity and things going on, I think that there is still some positive, and luckily there are some politicians who are dropping sickle cell and whatnots amidst everything else. So I'm staying hopeful that we will continue to be able to offer these treatment and sources for our patients.
You know, I fully agree with you, Maya, and I share your optimism about this as well. I think we are really on the cusp of something amazing. And when we feel so diminished and discouraged by the current political climate, you know, I would encourage you, like, think back on that slide I showed you guys where there's those two pieces of federal legislation that have passed. The first one was signed into law by Richard Nixon, and the second one was signed into law by Donald Trump. And so there are ways by which we can work within this very convoluted, terrifying political system that we live in now to be able to move the needle. I don't feel hopeless. I feel like there's things we can do.
People need our positivity, because I think people, it's dark times right now, but I do believe and feel the same way. Awesome. Does everybody, you can see in the chat, think your incredible, amazing work, fantastic presentation, how wonderful. Does anybody want to come off mute and ask or say any comments, questions, etc.? Otherwise, we can give 5 minutes back to everyone's morning. Done. I'll call that at once. All right, perfect. Well, thank you so much. This honestly is such a pleasure. I'm just as obsessed as I was several years ago. So thank you. I hope this was inspirational to everybody listening and just really giving us, turning pain to purpose and making sure that it's just, we are committed to this community and making change. So I'm happy to be on board with all of you. Thank you guys so much. Happy Tuesday, and we'll see you next month.
Thank you all.
Sonia, do you have anything to say before
I'm sorry?
if you, okay, I didn't know.
Oh, no, I was just saying thank you. No, it's just saying
And
thank you.
don't forget to get your CEUs. Thank you, everybody. Take care.
Bye, everyone. Thank you.